Good evening, everyone. Welcome to tonight's webinar, Protecting and Maintaining Your Vision and Hearing as You Age. I'm Donna Sunderland, the General Manager of Clinical Governance and Clinical Education at Montefiore. I begin today by acknowledging the Gadigal and Bidjigal people, traditional custodians of the land on which we meet today, and pay my respects to elders past and present. I extend that respect to Aboriginal and Torres Strait Islanders who are joining us. We are thrilled to have almost 100 people registered for tonight's event, so thank you. The Montefiore Spotlight Series discusses perspectives on ageing and addresses issues that affect older members of our community and their loved ones. Each session will explore aspects of ageing experience, including health and wellness, research and innovation, supporting older family and community members. Tonight we'll be talking about common eye diseases, diagnosis and treatment options, treating balance and hearing loss, the importance of preventative screening, supporting your loved ones who have low vision and poor hearing, and things to do at home and in the community to maximise independence. This evening, I'm thrilled to welcome three experts who will act as panellists: Dr. Djeldjevic, who specialises in cataract surgery and in particular is experienced in performing cataract surgery on patients with coexisting and often challenging ophthalmic diseases, such as glaucoma and retinal pathology. She has performed thousands of cataract operations and works as a comprehensive ophthalmologist, treating a variety of eye diseases. In 2016, she became a co-founder and director of Beamers, a company whose aim is to protect children from ocular IV damage with maximally protective sunglasses. Dr. Djeldjevic graduated from medicine at New South Wales University, in 1997 and completed her ophthalmology training at Sydney Eye Hospital. In 2006, she completed her fellowship and further gained training in glaucoma, medical retina and cataract surgery. As a leader in her field, she continues to expand her knowledge and experience in areas such as advanced surgical techniques through conferences and collaborations with colleagues in Australia and overseas. Alina has been appointed as a senior clinical lecturer at Sydney Medical School, and Dr. Djeldjevic has published research papers in peer-reviewed ophthalmic journals and book chapters. She sits on the organising committee for scientific conferences and she's involved with ophthalmic teaching. She regularly presents at ophthalmology and GP conferences. We also welcome Maxine Lodge, clinical audiologist at Hearing Australia and Next Sense, specialising in the assessment and the management of both adults and children with complex hearing needs. Her expertise includes developing personalised rehabilitation programs that integrate the latest technologies and evidence-based practices to address unique challenges faced by her patients. Maxine collaborates closely with interdisciplinary teams to deliver comprehensive care, ensuring each patient receives holistic support. In addition to her clinical work, Maxine has previously been involved in community outreach initiatives in the Northern Territory, where she advocates for greater accessibility to auditory health services. Her commitment to improving communication and quality of life for individuals with hearing difficulties drives her passion in this field. Finally, welcome Jo Russell, Senior Nurse Practitioner working at Montefiore, who specialises in the care of older people. As a registered nurse of 30+ years and a nurse practitioner of 12 years, her primary role in the context of sensory loss has been across facilitating communication and social engagement in the context of hearing impairment, assisting people with vision impairment to continue to perform activities of daily living and to achieve their life goals. Recognising challenges or deficits and referrals are made to specialists for treatment and services that can maximise sensory abilities, and having used those specialist services to assist patients to successfully adapt to them and put them into practice. Welcome, everyone. We'll now move on to our panel questions for discussion. The first topic: many people associate older age with poorer vision. It is true there are many eye conditions which are common in age. Alina, would you share with us and at the audience some of the most common eye disorders associated with ageing and the key signs and symptoms to watch for?
Sure. Thanks, Donna, for that lovely introduction, and thank you also to the Montefiore for inviting me to be on this panel. Unfortunately, like many things, eye diseases do not improve with age. However, certain diseases have great treatments and, in fact, can lead to visual improvements, such as from cataract surgery. The most common eye diseases in our community are, in descending order, age-related macular degeneration, or ARMD, glaucoma, and cataract. Macular degeneration causes a loss of central vision. So people see distortion, they have difficulty with reading, and in later stages, they can have difficulty with recognizing faces and even the food on their plate. There are two types of macular degeneration. There's dry, which is slowly progressive, and using vitamins can assist with reducing the progression rate. And then there's wet macular degeneration, which reduces your vision fairly rapidly and can be treated successfully with injections into the eye. The second cause, commonest cause of eye disease is glaucoma. Glaucoma is a disease of the optic nerve. So the brain is connected to the eyeball by a big nerve called the optic nerve. When this nerve is affected, it takes away your peripheral vision. Unfortunately, the peripheral vision restriction you don't notice until the disease is very late. And it's called the silent thief of vision for that reason. So the important thing with glaucoma is to know if you have a family history of glaucoma, in particular in first-degree relatives. And therefore, start your screening 10 years prior to the youngest member. Glaucoma screening involves having your intraocular pressure measured, having the thickness of the front surface of the eye, the cornea, measured. And then we do tests that both look at the optic nerve. So I would have a look on a microscope or a slit lamp at the optic nerve and do scans of the optic nerve, as well as functional tests, which are called Humphrey visual fields. The glaucomatous disease, so we know half the people out there in the community who have glaucoma, they don't know that they've got glaucoma. So once you get diagnosed, there are a number of treatments, including drops and laser and surgery, and they're very effective in maintaining your vision. So it's worth getting tested. Cataracts also are increased as you get older. Cataracts cause symptoms. They cause vision to be blurry, difficulty with driving or glare. And it's your natural lens that you're born with that focuses the light on the back of the eye. And instead of being nice and clear, it becomes frosty or misty, and that's a cataract. Cataracts can be readily treated with cataract surgery by removing the frosty or misty lens and replacing it with a new lens, a new artificial lens. The treatment is extremely successful. It's a quality of life surgery, and it also leads to the reduction of other terminal events such as falls.
Thanks, Elena. On to the next question. How do dementia, diabetes, and other neurological disorders impact vision? And what strategies can we use to help individuals with cognitive decline optimize their vision and effectively use glasses, especially when communication and memory are impaired? Thanks,
Donna. That's a difficult problem that obviously the disease that you've named are neurological diseases. So effectively, people will have pretty much normal eyes, but the level of the problem is in the wiring of the brain, in the nerves of the brain. So they're global diseases that can be from dementia or stroke or other vascular diseases, and affects the pathways. So we need healthy eyes, but we also need a healthy brain to be able to interpret the image that the eye or the camera sends. Having said that, being aware of the problem, for example, someone who's had a stroke may have the absence of a visual field on one side, like on the right side. They can learn techniques that I'm sure Joe can elaborate on further, which are called screening techniques or scanning techniques, where they can learn to move their head to the other side to use the area of functional vision to compensate for the areas that are missing. So people can be taught various things. And in the case of diabetes, once again, screening is very important. Diabetes can cause both central and peripheral vision loss. And with the dementia patients, it's very important, like with all the global treatments for dementia, dementia affects many parts of the brain, so many aspects of vision as well. It's important to clearly label glasses with what they're for. So TV glasses should have TV, reading glasses should have in big print reading and be put next to the books or the Kindle or whatever it is that the person likes to read as a way for them to remember. It's also good to tie in things with memory. So I always try to tie in drops or other treatments with meals. People usually remember to eat. So if they're eating 3 times a day and they need to do other things at the same time, I try and tie it in with that. Or I ask them to leave drops at the bedside where they're, before they turn off the lights, it reminds them to put the drops into their eyes. The other thing with dementia patients is that they may not necessarily complain of visual loss or any other deterioration. So it is more important to have these people screened and treat any treatable disease. And when I look at their treatment options, I try to choose methods that are going to be easy both for that person and for their family and for their carers. So if they're drops, we try to use drops that are 2 products within the 1 bottle. I prefer to use laser or even surgical techniques to really take the that off the patient and off the carers and the family. And particularly with cataracts, we try and do the cataracts earlier so that the dependence on glasses is less, and that will improve their overall functioning as well.
Thank you, Elena. That's some really practical advice there for everyone out there in the audience. Next question, I think maybe we'll pose to Jo. How can we encourage socialisation for individuals experiencing hearing or visual loss? And what steps can family and friends take to support their loved ones in staying engaged and participating in social activities rather than withdrawing from them?
Okay, thank you. So I think it's really important to engage with people and give them control over what they're experiencing and seek their feedback. Listening to them, getting on their level, speaking slowly and clearly to them, maintaining eye contact. Yeah, and then hearing what they have to say about their experience, what's working for them, what's not working for them. Use your body language. Even if a person has a visual impairment, they can still pick up on the energy that's coming from you because you're expressing yourself using body language. You can use alternative communication device, even something simple as pen and paper, but also there's IT solutions now for written communication that people can write on boards that are easily able to be erased. You can use online communication and headphones. If you're planning a family or a social event, you would want to include them in the planning of it. So making sure that it's something that they would like to do. You're trying to optimize them being involved in a family gathering, for example. Think about the travel time so that they're not going to get there and be really tired. Or if they are, allow them to have a bit of a rest, so that they're going to be at their best when they're trying to communicate and overcome any difficulties that they're having. And then maybe after a social occasion, debrief with the person, say, well, what did you find worked for you? What could we do differently next time? That'd be some of the things that I would think about.
Thanks, Jo. Some great ideas there for us. Back to you, Elena. What steps can we take to maintain healthy vision as we age? And could you discuss some preventative screening measures and recommend how frequently eye tests should be conducted and some lifestyle choices people can make to lower their risk?
Sure, thanks, Donna. So the two things that you mentioned, unfortunately, we can't do much about. Don't age, and choose your family better, who've got no eye diseases. But apart from that, even though we can't alter our family history or our genetics, it's good to know them. So ask your family members while they're around about any history of eye disease. And as I said before, in particular with glaucoma, it's good to start your screening 10 years prior to their diagnosis. So for example, if your brother was diagnosed at 60 as having glaucoma, the first degree relatives, parents and siblings, you would start screening at 50. With macular degeneration, often they present quite late because one eye has already been damaged and the other eye will compensate. And then it's once the other eye starts going, the good eye, people present with symptoms. So once again, really important to know your family history. And if you come early, those changes can be seen and we can discuss what could be done. In general, if you maintain your general health well, it also affects your eye health. So control your blood sugars if you're diabetic, and mostly for everyone should be doing that anyway. Control all your cardiovascular risks like your blood pressure and heart rate and cholesterol. Get your sleep apnea tested. That's one that people don't really think about. But as I said, the brain is connected to the eye. The eye is basically an extension of the brain. So if you're starving your brain of oxygen, you're also starving your eye of oxygen. And then another one that people don't think about is steroid use. So steroid in any form, so tablets or puffers for asthma or even nasal sprays or creams, can increase your intraocular pressure, and in particular in people who are susceptible to getting glaucoma in the first place. Certain eye diseases or conditions such as extremes of power, so in high myopia, so people who are short-sighted, or in hyperopia, people who are long-sighted, they can have increased risk of glaucoma and also of retinal detachment in the case of high myopia. So know whether you are in any particular category. For most people, the things that are in our own hands are eating a good diet. And we've all heard about the Mediterranean diet, and the Mediterranean diet applies just as much to the eyes as it does to the rest of your body. In the case of dry macular degeneration, there are some vitamin preparations that have been studied. If you have particular changes, moderate disease, they do reduce the progression of moderate disease to wet macular degeneration by about 25%. And you can Google those vitamin preparations. In terms of other healthy things, keeping a healthy weight, not smoking, exercising regularly, and then protecting your eyes, in particular from trauma. So when you're playing sports like squash or tennis or skiing or biking, protect your eyes with eyeglasses, as well as protecting them from UV eye damage with properly maximally protective glasses. And I've got a bit of a special interest, as you mentioned before, Donna, and we'll give you all the website links at the end of this, but I'm just going to finish the UV eye safety to say that small kids are particularly susceptible of UV damage. UV damage can cause cancers around the lids and on growths on the eyeball, and some of these diseases later in life. So look after your kids and grandkids. In terms of screening, probably under 40 every 5 to 10 years would be right. 40 to 54 every 2 to 4 years, and then 55 to 64 1 to 3 years. And as you get older, 65-year-olds and above, every 1 to 2 years. And obviously, if you've already got a family history of eye disease, or you've got known eye problems, or any chronic illnesses like diabetes, or are on medications that your doctor had said these can affect your eyes, you should come more often.
Thanks, Selena. Very comprehensive. So one more question before we let you off the hook for a little while. Are there any warning signs or symptoms I should look out for to indicate a serious eye condition?
Yeah, thanks, Donna. Certain eye conditions do need treatment in a timely fashion. And the three main ones of those, so anything that presents with a sudden loss of vision or visual disturbance needs to be seen, and that can be a result of wet macular degeneration or some other vascular event. There's a condition called giant cell arteritis, which is a systemic, so a full body rheumatological condition that requires urgent treatment if you start getting eye signs as a result of that. And you can also get vein occlusions for various other vascular things within the eye. So sudden loss or disturbance of vision, number one. Number two, severe and sustained eye pain, which can be caused by inflammation such as uveitis, or angle closure glaucoma, which is a specific type of acute glaucoma that can cause visual loss very suddenly, unlike the common form of glaucoma, which usually occurs over years. And it could also be an indication of optic neuritis. The other thing is if you lose part of your vision, so when you're looking at a picture and say the corners are missing, or it's associated with floaters, so things floating around in the vision, or flashes of light, this can be an indication of a retinal detachment, and that condition requires fairly urgent surgery. And that's in particular in the context of being very short-sighted, or once again, trauma or having a family history.
Thanks, Alina. Okay, in a noisy world, the importance of good hearing is often overlooked. However, research shows a strong connection between hearing health and overall well-being. Maxine, can you explain the most common types of hearing loss associated with aging?
Yeah.
What are the signs and symptoms? Sorry, this is a double-barrel question. What are the signs and symptoms we should be aware of? And can you share the best way to protect your hearing as we age?
Sure. Thanks, Donna, and thanks, Montefiore, for setting this all up. I've already learned a lot from both Joe and Alina. I'll be hitting that Mediterranean diet as soon as this finishes. I want to explain a bit about hearing and hearing loss, particularly as we age, just with a small picture to demonstrate. Hearing loss as we age, the stats show us that it takes the average Australian 7 years to actually do something about their hearing problems. And we know that early prevention, early identification leads to better outcomes long term. So I want to explain a little bit about the ear. So you should all be able to see my ear. This is the part that we know, the beautiful pinna. And there's lots of different things that can go wrong within the auditory system or throughout the ear that can cause a hearing loss. But focusing on today, hearing loss as we age, I'll be talking more about presbycusis, and that's the hearing loss that's associated with aging. It often has a genetic component, so knowing your family history can be really important. But it can also happen to people without any family history. So this is the part that we know. In a normal hearing ear, the sound goes down the ear canal, vibrates the eardrum, and then that movement of the vibration moves these little bones. And fun fact, these are the smallest bones in your body. And then that vibration hits the cochlea. So this cochlea over here, that spiral looking device, that is responsible for encoding speech and sending that sound via the auditory nerve to the brain. In a typical aging hearing loss, what's happening is there's thousands and thousands of little hair cells inside the cochlea that are damaged. And so they can't encode speech as clearly as they once did. If we took the cochlea and rolled it out, because it's all spiraled up, you would have what looked like a piano. So on one side would be low pitch sounds, on the other side would be high pitch sounds, and the keys are essentially those hair cells. Once those hair cells are damaged, that's it. There's no way to rejuvenate them. There's lots of research going into how can we bring these hair cells back to life. To this point, there is no way of bringing those hair cells back. As I said, it can be a genetic cause. It can also be blasting loud noise or music or loud concerts and things like that. So often we have a lot of clients that come in that have a history of working in really noisy environments. Maybe they were in the army, maybe they were just rock concert band members, but we see that their hair cells tend to be affected. So first thing is protect your hearing when you're in loud environments. The other thing about these hair cells being broken is that whilst hearing devices can amplify, what that's doing is it's making whatever hair cells that are left try and work as well as they can. It's like playing a piano with half the keys missing. There's no miracle cure, but the earlier we start to diagnose these types of things, the better. And because we want to keep that stimulation from the cochlea to the brain active, we want to keep that auditory nerve being able to encode speech. So number one thing is get your hearing tested regularly, especially if you're over 60 years old. Every 1 to 2 years is the recommendation. The other thing to be aware of when to start noticing that someone or maybe a loved one's hearing is deteriorating, there are lots of telltale signs. It could be asking for more repeats, not being able to hear on the phone anymore, putting the TV up is a big one. But a lot of the time, the first sign is really their inability to cope with noisy environments. We all find noisy environments harder to hear in compared to quiet environments. It's harder for the little hair cells to encode speech and separate it from noise, so it's hard for everyone. However, when a hearing loss is starting to progress, that's the first area that we find it's affecting, especially for age-induced hearing loss. And that's because the high-pitch hair cells, if we rolled out that piano again, those high-pitch hair cells are the ones that are deteriorating first. And the high-pitched sounds are really important for clarity of speech. They give you the t, p, k, sh, f, h. So often you'll find that in a quiet environment, you can communicate with your loved ones. But when there's noise, that masks over those high-pitched sounds. And so they can hear that you're talking to them, but they may not understand every word. And that's the first sign to get their hearing tested to see if there's anything that can help support them in that environment. Early testing. The other thing to be aware of is if they are complaining of things like tinnitus, so that's ringing in the ears, that is very normal. 90% of people get tinnitus at some point in their life. It's not necessarily a cause of hearing loss or associated with hearing loss, but it can be associated with hearing loss. So having your hearing tested if you find there's been a change to your percept of tinnitus, so a ringing in one ear or both ears, if it's bothersome, things like that, get your hearing tested.
Okay, thank you, Maxine. So maybe my husband does have a hearing problem, not just a listening problem. Okay, so how can hearing loss be attributed to aging, and can it be reversed or improved? And what hearing aids or assistive devices are available for age-related hearing loss? And how do I know which ones are right for me?
Yes, so it cannot be reversed. So that's something that I may have touched on already. Those hair cells, once they are gone, there's no rejuvenating them. However, there is technology that's available. I think that the main thing to be aware of is that it's not a miracle cure, okay? So often people, they put off their hearing loss for so long. They finally come in because they're really struggling, not because they're noticing small signs, but it's because it's really bad. And hearing loss, it doesn't just affect the person that's dealing with it, it affects their whole circle. It's frustrating for everyone, Okay, so they put it off for so long, and then when they finally come in, they expect some miracle cure to pop on some hearing aids and everything's going to be back like they were 20 years old. And that's not the case. Okay, the earlier you do something, the more we can get that nerve stimulated so that we can get a better outcome. The main things that we look at when we're fitting hearing aids, there's lots of different factors. It could be their degree of hearing loss, and that can impact the style of the hearing aid because we need enough power. It could be the environment they're in. So when you're taking a loved one to see an audiologist, something to be really clear about is what type of environments they find themselves in. The type of technology we would recommend would really be based on, are they in noisy environments regularly, or are they more of a homebody? Are they a homebody because they can't hear, or because they prefer that lifestyle? In a quiet environment, the hearing aid just needs to amplify the volume. But in a noisy environment, it needs to separate what is speech and what is noise, and that's a really difficult environment for the hearing aid to work at. So you may need a more advanced hearing aid to assist with that. The other things that we think about are management. How are their dexterity? How's their vision? Will they be able to manage tiny little batteries in their hearing aids, or do they need rechargeable solutions? Can they feel where their ear is to put something in their ear? Or is a different style that's chunkier, maybe more visible, which people hate to talk about, but maybe something that's easier to hold will be easier for them to actually manage independently without needing to rely on their loved ones to help, to assist putting them in. So all of these things we take into consideration. We also look at cognitive ability. For some people, maybe a headset is more appropriate. Maybe they aren't communicating with a lot of people. Hearing aids are difficult for them to manage. Maybe wearing some headphones connected to a device is going to be best for them and their family. It's really based on the client's goals, environment, management, the whole picture. We don't look at an audiogram, which is a snapshot of someone's hearing, and say that's the device for them. We need to take into account all of the other factors that could be impacting them to help make it as easy as possible. And sometimes working with the families of the people that are spending time with the person with hearing loss can make a big difference, because often I see clients and they say, oh, I don't talk to anyone. I don't really do much. I just watch TV. And then at a one-off, they bring in their daughter, and the daughter says, we want her to be involved in family meetings. She doesn't want to come. She doesn't want to participate. And we don't want the hearing to be impacting how well they are participating in these environments. We want to make sure that everyone is aware of how best to accommodate and make strategies to help the person that's having the hearing issues.
Okay, thanks, Maxine. The burning question, what are the common initial reactions or feelings people experience when they start wearing hearing aids, and how can loved ones support? You've touched on this a little bit, and to encourage them to continue wearing the hearing aids consistently. Yeah.
So I think in a lot of ways, because the hearing loss is pushed, the hearing aid fitting is pushed back for so long, 7 years, as I said, it can be quite an overwhelming experience to be fit with hearing aids for the first time. I've had clients tell me when they flush the toilet for the first time, they feel like there's a tsunami. Or when they put the indicator on the car, they are frazzled. I even had one client tell me that they were driving and they thought there's something happening with the hearing aid. It's broken, it's broken. There was something moving around in their boot for 12 months maybe that they've never been able to hear. So because we push this out for so long, it can be an overwhelming experience. What I recommend is starting in a quiet environment. As I said, noise complicates things for all hearing aid users. So when they first get their hearing aids, it is beneficial to start using them at home, around the house, where they feel comfortable. But not to stay at that level for too long. We want to get into the habit of wearing them every day, morning to evening, obviously not in the shower and not when you're sleeping, but putting them in when you brush your teeth, linking them to a habit. So similar to what Alina was saying, we want to make it linked to something else that they may be doing that will remind them, oh, it's time for me to put my hearing aids in. But it does take acclimatization. When you're not used to hearing those sounds for so long, it is difficult to accept them. I always use the analogy of a buzzing fridge. I recently got a new fridge. It made this buzzing noise. It was very distracting. I said to my housemate, we have to get rid of it. There's nothing that we can do. We have to get rid of it. It's too noisy and it's bugging me. Few weeks went past, and if you ask me, hey, does your fridge still make that noise? If I concentrate on it, it does. It hasn't changed. But the brain is an amazing thing, and it acclimatizes. It uses the environment that it's receiving information, and it decides that it's not important for you to hear the fridge, and you don't focus on it anymore. It's the same for people that live under flight paths. You know, when people go to their house, they think, oh, I could never live there. But your brain adjusts. And so by wearing the hearing aids consistently every single day, you get used to that overwhelming sound, which is just the sound that you should be hearing. And you learn to adjust and to keep that nerve stimulated. The other things that family members can do, I know that a lot of families come to me and they say, oh, it's okay one-on-one, but as soon as there's a few people, it's really challenging. And then you ask more about that, and often the family's sitting like this at dinner, or they're eating, or the lighting is really poor in the environment that they're in, or they have washing up going on right around the room. These types of environments are really difficult for hearing impaired people. We want to make it as easy as possible. And I'm just going to share my screen again to show you that navigating in a noisy environment requires everyone to come to the table. So these are just a few strategies, and we will send this out when you have the recording. But you want the person that has the hearing impairment to sit with their noise behind them. It's a bit counterintuitive sometimes. You want to put them in the quiet spot, but you want them to have their back against all the noise and facing the quiet spot. And that's because the hearing aids have directional microphones. So they're going to assume that what the person wants to hear is in front of them and not behind them. So facing the person that they want to talk to. If possible, choosing environments with soft furbishing, so carpet, anything with really high ceilings, hard surfaces, the sound just bounces on all the walls, and it can be really challenging for the hearing aids to interpret that. Moving away from the noise source can be really beneficial. Asking people to speak slower rather than louder, okay? A lot of the time you tell someone, oh, I have a hearing loss, and they start screaming at you, and they don't need more volume. Remembering back to those hair cells, they don't have the clarity. So speaking slower is more beneficial. We can use different microphones and remote microphone systems, and I won't go into that too much, but that's essentially picking up the communication partner wearing the device, and it picks up their voice and sends it to the hearing aids. And that's the best thing for noisy environments or distance between you and the speaker. And just thinking about the lighting, and we've mentioned that already. So thinking about having enough lighting that they can see your face. We all use visual cues more than we think. So having that access is very beneficial.
Thanks, Maxine. This is the million-dollar question. Can you share best practice for safely removing earwax and some of the misconceptions in the community? And it's so important to share best practice.
Yeah, Joe and I were talking a little bit before about wax removal. Essentially, the best practice is that if the ear canal is blocked, so occluded, then we want the wax out. You can imagine if someone already has a sensory neural hearing loss, so that's the hearing loss where those hair cells are not working. If you have a blockage getting sound into that as well, it's just going to make it that much harder. The important thing to consider is that we do need to soften the wax before it comes out to avoid any damage occurring in the ear canal. You can use Waxol drops for a few days until that wax is really soft and then get it flushed out. Or you can use a clean ears spray. That's a pink bottle from the chemist. It has peroxide in it, so it actually tries to fizzle down the wax rather than just soften it. If there is a full ear canal of wax, you're likely going to need it flushed out. It's not going to get out quick enough. But the ear canal, it grows like an escalator. So the skin in the ear canal actually grows outwards. So firstly, don't put anything inside. No cotton buds, they should not be used. We do not recommend them. I've seen more damage from cotton buds than good. What that does normally is it compacts the wax. It makes it really hard and compact, so it's even harder to get out. So as doctors often say, nothing smaller than your elbow should go into your ear. But using the wax drops for a few days and then seeing a nurse practitioner can be beneficial, or using the clean ear spray and seeing if that disintegrates the wax. If you are a hearing aid user or your loved one is a hearing aid user, then the wax can often get stuck in the hearing aid, and that's when we want a little bit more regular wax management, making sure that you're cleaning the hearing aids, because as that ear canal is bringing the wax out, it's obviously getting stuck in the hearing aid, and that can impact how well the hearing aids are working. But wax is normal, okay? It is a very normal part of the ear, and so people often get self-conscious. They're like, oh, do I have wax in my ears? It's okay, as long as it's not blocking that ear canal.
Okay, thanks, Maxine. I can see everyone after the webinar charging to the bathroom to hide their cotton tips. Okay, Jo, in your role as a senior nurse practitioner, you focus on improving clinical outcomes and quality of life through assessments and interventions. Can you share some of the adjustments individuals can make to their homes to support low vision and hearing loss? You've touched a bit on this earlier, but if you could just elaborate a little more.
Sure. Thanks, Donna. As we get older, we are less able to see greens and blues, and we're more able to see warmer hues like red and yellow and orange. So contrasting colors, contrasting objects in those colors is easier to see. And in the same way, a red light in the hallway at night is easier than just an ordinary night light. So attention to lighting can be really beneficial. If you have particular activities you want to do, you might want to focus a certain type of lighting for that. For example, reading or light in the kitchen and things like that. We can have a look out for hazards. So we could do a bit of an audit of the environment and find out what is likely to be tripped over or cause some sort of other hazard. And sometimes you can get an occupational therapist to help you with that. We can use alarms to notify of dangers. For example, if there's like have a smoke alarm or a gas alarm, so that the person is triggered for a sensory loss, they might not be able to smell something like that or react to something so quickly. And those alarms can be actually targeted to reach out to other people. For example, your family member, to let them know there's an emergency in the house. We can use textures. We can use different carpets, and often people will be able to sense the difference between a bathroom tile, for example, and the hallway wood, which can orient them to the environment. So if they've got a visual impairment, they may be more able to feel where they are. And in the same way, air currents can be used. If the person does what's called sensory development exercises, they can actually use their other senses to improve their understanding of where they are in the house, just by feeling breezes or cool air or hearing a different echo off the tiles and those sorts of things. Smells may orient a person to where they are. For example, the bathroom could smell like a disinfectant sort of smell. Aromas of the kitchen might orient them that they're entering the kitchen. We can use access technology, and I think we're going to touch on that later as well. Some new innovations in IT that can be used to improve people's other sensory abilities to complement their hearing and vision loss. Touch, human touch can provide great reassurance, and reassurance can help a person to just calm down and therefore be at their best to hear and to receive visual information as clearly as they can. We can use visual memory to create a working picture of their most common environment, so that they we reduce clutter, so it's as simple as possible, but then they'll know that that's always where I put my keys, or that's where I put my medication, because they have developed a strategy, and then they have like a visual memory of their apartment or their living environment, and they can know their way around that environment through familiarity. So there's some strategies for you.
Okay, thanks, Jo. We've already touched on some medicines and treatments, but are there any concerns about common pharmacological issues with over-the-counter medications that with people, there's not so much focus, maybe communicating with local pharmacists and looking for side effects?
Yeah, sure. There are some medications that are what we call ototoxic, which is they actually cause damage to hearing. But what I would probably say to people is that the most important thing with medications is to know what your medications do and the side effects of them. And if you don't know what they do, well, you can ask for a home medicines review with your local pharmacist, or you can speak to your health provider, your prescriber, about the medications that you're taking and what could some of the side effects that I experience, what could they be related to? Some of the classes that medications that are particularly concerning for the hearing are some antibiotics, some diuretics, chemotherapy, even high doses of aspirin. So there are a lot, and that's probably a little bit above the knowledge level of the general public. It's why it's good to have a health professional that you can trust to ask you to go through it. With polypharmacy, which is describing a person that takes 5 to 9 medications at the same time. Unfortunately, all medications, and this is including the ones that we buy over the counter, they all are basically competing in the body to become the most prominent medication, I suppose. And in that complex interplay of different medications, some medications come out on top and some are not so prominent, but they interact with each other, and it's quite complex. The more medications you take, the more complex that will be, and the likelihood is that you will be experiencing side effects if you're taking more than between 5 and 9 medications at once. So my recommendation would be to get to know your health professional, ask them what medications you're on, and ask them, could there be any interactions with the medications? Could these be leading to problems with my hearing or vision? And ask your pharmacist if they can do a home medicines review for you, and then they can forward that information to your general practitioner or whoever else is your prescriber.
Thanks, Jo. That's great advice. Okay. So the next question is to all. Following the most recent COVID pandemic, was there an increase in awareness of the impacts of sensory loss and quality of life? And can you share the importance of therapeutic benefits from leaning on our other senses? I think working in aged care, this was a very big challenge for us, and we've certainly learnt a lot, but would anyone like to share their experience?
Well, I'd like to say that probably one of the most difficult things about COVID was the fact that we wore masks.
Yes.
Because people weren't able to lip read anymore, and we didn't realise how much they were doing that. Obviously, isolation in like your apartment, your house, or your room, if you live in an aged care facility, was particularly distressing and led to some really difficult outcomes for people because they had less stimulation, and it led to all sorts of complications. So that's kind of my perspective.
In my experience as a facility manager, we had a day when one lady who had mild cognitive impairment was commenting, coming up to all of the staff from, all the nurses, the leisure and lifestyle people, and she was commenting on everyone's eyebrows. And this went on for the whole day, and everybody's sort of wondering, what's happening? And then we realised that that was the only part of our face that she could actually see. So she was focusing on everyone's eyebrows. So the nurses all decided to wear very exotic eye makeup for a couple of weeks just to make a bit of fun, but it really had an impact on me. Okay, so moving forward, this is another question to all. With advanced technology always emerging, can you share some opportunities and available technologies to assist with communication for ageing people into the future with low vision and hearing loss? an exciting space.
Can I just start with adding to Maxine, who was saying about having the noise behind you. If you can remember having the noise behind you, remember to have the light behind you as well. So when you're reading and doing visual tasks, the noise and the light should both be behind you. With regards to technology, there's a lot of emerging technology and it's all very exciting. I would direct you to Vision Australia, who have various devices, and they can also do a tech assessment within your home to see what your visual requirements are. There's also another product called Iris Vision, which is goggles that they're using for macular degeneration and maybe glaucoma patients. So there's a lot there on the horizon. And obviously, as Joe was saying, when people are visually impaired, we try to use the other senses to compensate. So at the moment, we've got audiobooks, podcasts, we've got the ability to transcribe, translate, to change it to audio or touch or feel. So, but watch the space because there's a lot of exciting stuff. And in the operative space, there are lenses that can do various things as well.
Thanks, Elena.
Yes, I could.
Sorry.
I was just going to add, I could probably talk about this for ages because there's lots of new technology coming out, but it ranges, like Joe was saying, from alarm clocks that can vibrate the bed. So if their hearing devices are not being worn, they can still wake up to an alarm, or doorbells, or anything that can vibrate the bed and wake them up that way, which is quite a way to wake up. But it ranges even to kind of intercom situations that will be coming out. There's a new Bluetooth coming out called Auracast, which when you're at kind of airports, train stations, synagogue, anything like that, you'll be able to have, if any microphone is being used, that sound come directly through the hearing aids. Some of that technology is already out through something called telecoil, but it's not so reliable. In the next 5 to 10 years, this will be everywhere. So lots of cool stuff coming out.
Thanks, Maxine. We might move on to the chat. We're sort of a bit short on time, but Felicity's asked a question to you, Elena. Elena, my mother has Alzheimer's dementia and she's very mobile and active. She's been diagnosed with cataracts. She currently wears prescription glasses for all activities. Should we consider what are the questions we should be asking to understand the risks and benefit of cataract surgery for someone with declining visions and dementia? Thank you for the series. Would you like to answer, Elena?
Sure. Thanks for the question, Felicity. I think that the risks and benefits of cataract surgery with dementia are very similar to any of us, and you can discuss those with your doctor. However, the benefits for someone with Alzheimer's would be that she could probably get rid of a lot of her prescription glasses, and hence that choice of which pair of glasses for which activity would be out of her hands to some extent. I would encourage you to do or for her to have the cataract surgery earlier rather than later, because another consideration is how cooperative she would be with having the surgery. Most cataract surgery is done under local anaesthetic, so we don't like to leave it to a stage where the person is completely uncooperative and then we have to give them a stronger anaesthetic like a general, which then has flow-on effects for the rest of their body and cognitive function. So there is that sweet spot with doing it when the cataracts are there, but not waiting too long. And the beauty of the cataract surgery is that we don't really need a lot of information from the patient, because the measurements that we take to plan for cataract surgery, they're all objective measurements. So all the scanning and everything are scanning of her eye, and then there are lots of lens options to go into the eye after that.
Thanks, Elena. Denise has asked, dry eyes are more common with the age than the rest of the population. Are dry eyes more common?
Yeah, Yes, they are. Unfortunately, they're more common with age, they're more common with being female, they're more common if we sit in artificial spaces, which we all do. They're more common if you drive in the car with the aircon blowing in your face, or in the winter when you've got the heating on. In the interest of time, you can just try to modify some of those environmental factors. But the reality is a lot of people are using lubricant drops, and in particular preservative-free lubricant drops.
Thanks, Elena. I think we've answered another question about the best treatment for dry eyes as well, so thank you. Does tinnitus ever go away? This might be for Maxine, I think.
Yeah, it's a good question. It really depends on what the cause of the tinnitus is and if it is associated with the hearing loss. We don't talk about curing tinnitus, but learning management strategies for tinnitus. So it's kind of going back to that fridge humming scenario. If you can learn to zone that out, there's lots of different strategies that can be done, either from auditory stimulation, so wearing something like a hearing aid if you do have a hearing loss, or by other auditory stimulation. So you can have, you know, noises in the environment, have a, you know, low fan going. There's amazing apps and resources that you can have that you can set a timer to. So you could have, you know, the rain pouring at a really low volume for 30 minutes as you're trying to get to sleep. That will go off automatically, and it will just give you that strategy to manage the tinnitus prior to bed. It's usually right before sleep that people notice their tinnitus the most, because it's a really quiet environment. The more noise that's in the environment, the less the tinnitus is usually present.
Thanks, Maxine. Okay. Well, this
90% of people will get it. Sorry, I just saw that chat box come through. Will have it at some point in their life. There is a big link between tinnitus and stress levels as well. So managing stress can also impact that.
If it was only that easy. Thank you. So this is the conclusion of our Spotlight discussion. I'd like to thank our audience for tuning in and participating with the questions. We'll be sending a recording of the discussion to you all by email, and we'll share the contact numbers and further information, including some online resources that our speakers have mentioned. I'd like to thank Alina, Maxine and Joanne for their time and expertise. And thanks again for watching. Our next Spotlight will be held in 2025. Thank you.